The reason we are doing this is because every day folks are dealing with new pain that doesn't go away.
Pain's a difficult thing to understand, so let people know what kind of options they have.
Dr. Powers, this is our third podcast. Look at our comfortable chairs. Don't you like them?
They are very nice. Yeah, we got a whole new setup.
I really appreciate the comptroller springing for these.
Yeah.
We've got
a new name as well to the podcast.
We do, that's right.
Maximize Life Advances in Pain Treatment. Maximize Life Advances in Pain Treatment
That's
with
right.
Dr. Glazer and Dr. Powers. I'm Dr. Powers.
And I'm Dr. Glazer, and we're coming to you from outside of Chicago, Burr Ridge, Illinois, where our practice is. And this is our third podcast. And we wanted to start talking about one of the most common scenarios we see, the most common scenarios in the world. A lot of our patients have lower back pain. But before we do that, my daughter said, Dad, you really need to explain why you and Dr. Powers are qualified to do a podcast like this. And she has a point. And I want to give just a little background to show, why we have the information that we have to transmit to you. And basically, I'm 65 years old, and I've been doing pain management for over 30 years. And I really have seen this field, interventional pain management, develop. I've been there while it happened. The fellowship that Dr. Powers did, fellowships like that, there were maybe two when I was in my residency and fellowship. And they were very difficult to get into, and they weren't even using fluoroscopy at that point, which is live x-ray, which is what we rely on now.
Standard of care now.
Standard of care, all these things, I've watched it develop during my career, and the way I've been able to keep up on it is just constant continuing medical education, constant meetings, reading, conferences, cadaver courses. I've been for years, that's all I did to keep up on all these changes. And things will change for you. You'll eventually have to learn new procedures as well. But I have seen this field progress to where we now have so many more options than we used to. And now there is I've served on our national board of the American Society of Interventional Pain Physicians and our state board. I have published articles and published some book chapters. I have what else? It's just our experience mostly, though. I've seen thousands of patients. I've put over 1 million needles in people's spine, and I know that sounds crazy, but I've actually done the math because multiple procedures require multiple procedures. So I'm very well versed in this field. There again did not exist a board certification when I finished my fellowship. Now there's 2 board certifications, one by the American Board of Anesthesiology, which, congratulations, Dr. Powers, you just passed that.
Thank you.
And I think you passed with very high scores. I'm kind of stealing your thunder here. But that's why you're qualified, because you've just come out of a very good fellowship and passed your first board certification. But there's another board certification called the American Board of Interventional Pain Physicians that only a few hundred of maybe 300 or 400 people have passed in the nation, which is really a rigorous test of your competence, which I've passed twice now. So that's, Audrey, that's why I'm qualified to give this podcast. And Dr. Powers, I kind of stole your thunder, but go ahead, tell us about
my career. Not quite as long as yours,
right?
So quite. Far, but I hope to eventually get to that point. But yeah, my qualifications, I did training in anesthesiology in the Chicago area.
Right.
For my fellowship, that's where you learn how to become a pain physician. That's where you learn about pain medicine. I chose to leave the Chicagoland area. I wanted very comprehensive pain management training, and there are some great programs here in the city of Chicago. One of the things that I also wanted to learn more about was cancer pain management, and there's not a lot of places in the country that you're really able to dive into that. One of them is the University of Utah Health in Salt Lake City. Kind of has a unique cancer pain management program there. It's called the Supportive Oncology Group, and they're able to capture these patients who come in with cancer pain very quickly and treat them. So I had a lot of outpatient pain management, which is the more traditional type of chronic non-cancer pain management, where I saw complex patients who a lot of them had seen a few different pain doctors before and were coming for third, fourth opinion. Had a lot of patients that were coming in for cancer pain management as an outpatient as well, but then there was the other side. There was inpatient pain management that I did. So it was a nice breadth of knowledge that I was able to get from that fellowship. And then, yes, I'm double board certified by the American Board of Anesthesiology in both anesthesiology and pain medicine. I did do pretty well on both of those exams.
It's not bragging if you can do it.
Yeah. So, I was excited by that, and so my qualifications, I guess, come from my background in the training that I've done and kind of the breadth of knowledge that I've gotten from people who have been in the field for a while and really kind of defined what the field is today, and in your career kind of highlighting a lot of those changes in the field.
Well, and I want to add to your qualifications the fact that I interviewed you, a couple times. You came out. We've spent a lot of time in the operating room together. I've seen you work for the past few months, and Dr. Powers is a very good doctor, and he knows what he's talking about. He's exceptionally well trained. He is awesome in the operating room. I'm very impressed for such a young physician to be as skilled as you are. So kudos to you, and looking forward to you working with you for as long as possible. And what else was I going to say? The experience you had at Utah with cancer pain is fantastic. That's the way it should be everywhere. As soon as a patient with cancer maybe had gone to the emergency room once or twice because of uncontrolled pain, you guys got involved. The ER knew that you were there. They contacted your service. This is so fantastic. There's nothing like that in Chicago, I assure you.
Yeah,
if there is, I've not heard of it.
Yeah, I mean, there were patients who were coming into an emergency department in rural Idaho that were coming in for abdominal pain, had CT findings concerning for cancer, were referred to the University of Utah Health Huntsman Cancer Institute. Sometimes we were seeing that patient within a week of that CT scan, sometimes even before the cardiologist had even seen the patient. The oncologist had even seen the patient. So, these patients were getting care very quickly, and it was something that was truly foreign to me when I got there, because I haven't really seen anything quite like it in the Chicago area. So it'd be wonderful to bring those services to people in the Chicago area.
We're doing it. Yep. You're contacting oncologists. I'm sure your word will get out. It's really, I tried to do it when I was younger. It's just it takes a lot of bandwidth. I mean, you have have to have a lot of people involved, staff members. You got to get records. Patients are complex. Often they might be on blood thinners. Just a lot going on. Mm-hmm. You need all hands on deck. We've got a system now to support you as you create that program in our in this office. So I'm really excited about that. But let's go ahead and talk about something that vexes how many people in the population. I mean, it's 20% of people, or 20 or 30% of people are suffering lower back pain, or have suffered lower back pain.
Most common complaint that patients are going to see their primary care doctors for, number one.
It is. It's number one, lower back pain. Oh. The cost of the treatment of lower back pain are more expensive, I believe, than the cost of treatment of cardiac disease. Am I correct? About equal?
Yeah, that sounds about right. Yeah.
I mean, so much time and energy, and often, fruitless, the things we do. But we feel that we know that we are sitting in a position that we provide excellent treatment for lower back pain with excellent results, because we're treating the source of the pain. Basically, when you develop lower back pain and it doesn't go away, taking medications, doing physical therapy, that's fine, except there are long-term issues with doing that, and it's not treating the cause of the pain. The pain might go away on its own, right? That's good. That means the trend of the pain is going down over time. But if it doesn't go away, treating the symptoms is not a long-term plan. But on the other end, but treating the cause is difficult. It used to be impossible. I mean, treating the cause means getting in there and treating it. And up till the invention of our field, that was surgery, right? And surgery remains an option. But because our field has developed so many techniques for helping lower back pain, that we're helping people avoid the nuclear option of surgery because of the risk of surgery, which we've discussed a little bit.
Well, and risks, and also surgery is not necessarily associated with great outcomes just for pain control.
Well, that's a risk of failure.
Yep.
And then you've burnt a bridge because often after surgery,
your anatomy has changed.
Your anatomy has changed. You cannot find or treat the source of the pain.
Yeah.
And we think a lot of our viewers might be patients of ours and other patients around the country who they've had these treatments. The treatments that we provide, the treatments that we've convinced insurance are valuable to pay for. Joint injections in the back, nerve blocks in the back, radiofrequency ablation nerves in the back. We're going to discuss all these in detail at some point. Epidurals of 3 different kinds, interlaminar, transforaminal, caudal epidurals. These are kind of our basic routine procedures utilizing steroids and heat to reduce pain transmission and reduce inflammation. They work for a ton of people. I mean, they've worked for me. They've worked for my family members. They can have long-term effects, but in some patients, they don't, correct? And what we want to do today, just to kind of, because it's so exciting, we don't want to talk about the regular procedures today. We want to dive right into a new procedure. So for folks who have just started having lower back pain, this probably is not for you. This is for people who we've tried the treatment of the facet joints, we've tried the epidurals, and we haven't helped them. And so what do? We have this new procedure called, go ahead.
Basivertebral nerve ablation.
Yes.
Kind of the generic name. The first kind of brand of that would be the Intracept procedure.
Correct.
Yeah.
And I'd like to spend some time on that. Why don't we call an end to this podcast today as an introduction to the next podcast? And we'll talk more about the facet joints and things like that for educational purposes in the future. Is that okay?
That sounds great. Yeah. So in the next episode, we'll be talking about basivertebral nerve ablation, what it is, who would benefit from that sort of treatment. So we'll see everyone in the next episode. Thanks for joining in.
Thanks very much.